Okay, good morning. Thank you very much, Dr. Rosoff. It's a pleasure to be here. I want to recognize that one of my co-authors is in the audience, Dr. Jane Weintraub. My other co-author is watching via webcast, Dr. Gary Rozier. And it was a fantastic team to be working on this. Okay, we're going to be talking about health literacy as a key driver for integration of dentistry into primary care. Okay, Melissa? There, okay. There have been a long history of discussion regarding integration of oral health in medicine, but it really gained steam after the Surgeon General report in 2000 and the other activities like the workshop on the face of the child that were surrounding that. So if we move forward, the purpose for today's presentation is to just give a description of the environmental scan, which was to assess the types of oral health integration into primary care programs in the U.S., how health literacy is included in the integration efforts, the types of oral health training and education that provided to non-dental health professional students and through continuing education, and finally to prepare 4 case studies in which some organizations will be presenting today. First, we developed search criteria for the environmental scan. As this was an environmental scan, we included both peer-reviewed and the gray literature in this. And from that, we then identified, we gathered the literature, we identified experts who could talk knowledgeably about various components of this, also people who were doing IPE programs, foundation representatives who were organizing some of the studies, and funding this, and government representatives who also helped organize this. We then posted on listservs because we hadn't gotten that much particularly peer-reviewed literature. So we posted on 2 listservs, the health literacy listserv and the dental public health listserv about this project, and asked people who had studies that were underway and were not yet published if they would mind talking to us and sharing it. And what we excluded was interdisciplinary programs. So adding mid-level providers to a dental program was not a part of this environmental scan. We also would not do a standalone demonstration program if it was primary care into dental practice and a standalone public health program. So we kept it to a unidirectional review of oral health into primary care. So we're going to begin by looking at the results of the environmental scan. In order to do this, we needed to identify what scope of practice was for integration. And we addressed this by looking at guidelines or consensus statements or even national surveys that talked about what dentists were doing and physicians were doing. And I don't have time to go into all of the findings of what we looked at on this, but I want to make one important point. The U.S. Preventive Services Task Force 3 times did a review of integration questions, and only 1 time did they find sufficient evidence to make a recommendation. So I call this out as it's important because the 1 time where there was a recommendation was, sorry, I wasn't looking, was for the pediatric providers to conduct preventive oral health services, but when they looked at the coronary heart disease in 2009, they found that there was insufficient evidence to assess harms and benefits of clinical screening for periodontal disease. And when they looked in 2014 at oral cancer, they said there was insufficient evidence to make a recommendation. And this is important later as it calls out the lack of research that's undergoing on integration. Next, we set out to frame a conceptual model that would really be our underpinning for what we were looking at. And we wanted to combine models of integration and models of health literacy in doing this. And so we started out with the linear framework for integration from the IOM machine, product, and then we moved to, next slide please, the rainbow model of integration that highlighted 6 levels if you look along the bottom, functional integration and normative integration, and then 4 models from clinical integration up to system integration. So there are 6 levels at which integration can take place within an organization. And I'll explain the different levels as we move along. But if you look at the next one, we then took the rainbow model and we made it diagrammatically possible so that we could show that normative and functional integration were like the envelope that would be underpinning all other integration methods at the clinical or professional level. Okay, now we're going to now look at the 4 clinical categories of integration that we divided the literature into. The first of those was preventive oral health services provided by medical providers. Okay. The other 3 are the preventive health services provided by dental providers in primary health, primary dental, primary care clinics or non-traditional settings, case management, coordination, and referral, and preventive health services by a dental provider, but only if that was connected to other integration methods within the same article. Okay. The literature found 32 publications, of which 15 were peer-reviewed and 17 were in the gray literature. The programs represented 28 states plus Washington, D.C., the National Head Start Association. It represented statewide programs, countywide programs, urban, rural, focused on clinical and system-level quality improvement. There were multi-site programs in which it would be on a specific topic, like on pediatrics. It would be on type of practice in different settings, et cetera. So the literature is robust in able to say that it has been tested in multiple different venues. If we look at now at the preventive oral health services by medical providers, 37 of the reports mention something on POHS by medical providers. This was by far the largest. A report could have more than one example within it, however. So 33 of them were on pediatric preventive oral health services. 10 of them dealt with pregnant women, where the medical providers were doing an oral health assessment and referring to the dentist. 5 dealt with patients who had chronic diseases, and it was primarily diabetes. And two were not preventive, but they had to do with still trying to integrate into primary care, meaning that Maine and New Mexico had trained medical residents to perform extractions. They built that into either the emergency room doctor or family medicine on training them how to do extractions because they had a statewide problem with a paucity of dentists. Okay. If we move on to preventive oral health services provided by dental providers in primary care clinics or non-traditional settings, there were 16 examples. The dental services offered were generally offered by hygienists who had been integrated into a medical clinic, and they were offered to children, they were offered to pregnant women, they were offered in public health services that were an extension of the, in rural areas there would be a primary health clinic, the hygienist would be working off-site either in a school or somewhere else, and the physician would rotate in once a month. So there were a variety of different types of organizational structure around which they did this. The increased use of the emergency room was noted again in several publications, and again we found a couple of sites where institutions introduced dentists or dental residents into the emergency department so that there would be someone who could do definitive care for an emergency. These people were then instructed to try and triage these persons and get them into the dental clinics. Looking at case manager and coordination of care service and referral, we found that there were 22 examples. They had to do with increased access to dental services, access to community services, and social services support, such as transportation. They also offered increased access to health education and prevention through navigation to dental clinics. So basically, these were people who were trying to Different types of people included social workers, community health workers, navigators, nurses at times, and they were trying to assist patients to find the appropriate primary care location for their care. And some of this was also done using electronic tools to help with navigation, such as through referral. The preventive medical service by dental providers, we found 16 examples. We found that dentists would screen and refer for a medical home. They would refer for hypertension, HIV, and blood glucose levels. And even though we had restricted this, we were surprised that there were as many as 16 levels that had shown up in this literature. And the reason for that was because once an organization did one integration model and they found that it worked, they were more likely to move on and try another one. So this was often not the first, but it was a secondary attempt. So, for example, in Kaiser, dentists would review care plans to find gaps in the preventive services and immunizations, and then refer the persons to primary care. There is also an example of developing periodontal quality measures for diabetic patients. So, in summary, for this part, there is much interest in integration. However, there's little peer-reviewed research on it. There are a few guidelines established for such program, and most of the guidelines are in the direction of MDs doing preventive oral health services. Some pilots have been developed for how to implement a program, but few studies discuss the effectiveness or the outcomes of the programs in improving oral or general health. There's wide variety in the information about the programs, but there's little consistency. So it'd be helpful if people would say, if you're going to write about this, it would be helpful to know, this, that type of guidelines. And there's a variety in purpose. Some of them were done to educate people on how to integrate. Others were representatives about integration models. And some were in determining best practices for integrating oral health into ACOs. The strongest work toward developing an understanding of whether integration is successful is coming from the managed care and the accountable care organizations. We're now going to look at how health literacy is included in the integration efforts. Health literacy is a facilitator to integration. We use the multidimensional model, which we'll show now. Okay. And conceptualize the type of communication efforts that might represent health literacy at each of these levels. For example, there are numerous integration studies that talk about the importance of leadership in order to have a successful integration and to get the clinicians on board to actually do it. So here we included in the normative integration as a health literacy example, whether the organization's mission and value included integration of oral health into general health, and whether the leadership spoke about this as an important aspect. In the next 6 slides, I'll show you other examples from the environmental scan and from our case studies to facilitate integration. So, looking at first at the clinical integration, which is seeing how the clinical services are integrated across different times or places, we saw examples such as developing health literate educational materials in relevant languages, utilizing anticipatory guidance, either with children or with pregnant women or in other cases, or chronic disease patients, developing and utilizing case management and patient navigation to help make sure that, for example, the parents get their children to the dentist when they're supposed to for a year one visit. Guidance for asking patients about dental symptoms and recording in the record about the oral health assessment. Asking patients about medical and dental home and the last medical dental visit, and tracking and following up referrals. At the professional level, Professional level is the extent health professions share a common understanding of their role in coordinating comprehensive care. So here we looked at, for example, whether a department, say OBGYN, got on board and the physicians and dentists worked together to come up with what the training would be for the team and what the protocol would be for how to move the patient from one clinic to another. And Grace Health, the Grace Health FQHC case study is a good example of this one because the hygienist had been moved into the OBGYN clinic, but they found it was difficult to work there because they couldn't make the follow-up appointment for the patient in OBGYN's electronic health record. So Dentistry and OBGYN worked together to open up the dental appointment system in the electronic health record in OBGYN to make this more facilitated for integration. These were other examples. And then if you move on to the oral health, the organizational level of integration, this is the responsibility and shared accountability between organizations that are needed in order to coordinate patients for services. And above we see that developing common performance metrics or a dental referral network are examples of health literate attributes. In addition, a good example of this is the Willamette Dental Group and Intercommunity Health Network. The Oregon statewide health integration program included the requirement for organizations to develop pilot programs to address some of their necessary community problems. And they chose diabetes. And so to do this, the medical practices and the dental practices, which were separate, had to work together to develop a pilot program in which they would send education materials between diabetes and periodontal disease to the medical patients who had diabetes in the medical practice. And then the MDs were to ask the patient if they had been to the dentist in the last year. And if not, they had to do a referral, which was unusual. And their care coordinators, their nurses actually said, we're not used to doing referrals to dentists. And so then on the dental side, the dental clinic had to find the people who had a medical history of diabetes. They had to ask the patient whether they had seen their physician in the last year, and if not, do a referral. So it doesn't seem like much, but it's very difficult to change practice like that. At the system level of integration, this is the formal and informal political agreements that enable professions and organizations to deliver comprehensive care. And examples of health literate applications at the system level include determining the community's needs, seeking resources to initiate programs, and demonstrating good community participatory guidance. The case study in Health Partners provided a good example of a health literate application. They realized that their homeless patients were being released from surgical care and had no place to go where they could practice effective post-op care. So the senior management made an arrangement and paid for homeless people to be housed for several days. And that way, that also had the benefit of letting the patient know that the importance of post-op care was really important for them to have a good recovery. An example of the triple aim. At the functional level, we're looking at the support systems and people who coordinate the operations. Again, Health Partners described health literate applications such as their patient experience questionnaire to measure their patient satisfaction and their newly integrated electronic health record as examples of functional integration. You also see up here providing regular feedback on performance and developing systems and benchmarks for this. The Willamette group described a range of health literate applications, including common screening questions for diabetic patients, a communication group that ensured that all communications and outreach were tailored to the appropriate reading level and language. At the normative level, this is the outward look from the organization to the community in its interactions and assuring that the top quality and having a shared vision is important to the organization. In Willamette's transformation program in Oregon, This was statewide. So the integration partners brought it down to concrete steps for their collaboration by developing goals. They considered the social determinants of health. And IMB, which you'll hear more about later, they conducted a review of the physician language. They taped it and saw what language the physicians were speaking to the patients to determine that the patients would be able to understand this. And Grace Health described their mission as looking to fill gaps in the care system for their community. And they said that that was why they focused on pregnant women. Now I'd like to move on to type of training and education that's provided to health professionals and through continuing education. This method used a longer segment of published literature from 1995 to 2017 and looked at surveys of oral health curriculum, content, and IPE programs. Also looked at the HRSA-funded training programs and websites of over 40 non-dental professional association websites to find evidence of oral health content and CE opportunities. The environmental scan identified a number of challenges to integration of oral health and health professional education and practice. We knew that medicine and dentistry were siloed, but it became evident that just the sheer number of dental schools created unique challenges. There were many more U.S. medical schools, so many campuses and academic health centers don't have a dental school to integrate with. And even when they're on the same campus, there are challenges such as different schedules, different cultures, and a lack of interest in trying to change curriculum. Before 2000, oral health was almost non-existent in primary care provider education. It's now included in both of the profession's accreditation standards, but the outcome is still not great, less than 5 hours in the entire curriculum. And like the integration practice literature, there's little published peer-reviewed literature on integration in education or on changes to patient outcomes. Continuing education is critical for training professionals who are in practice and not involved in an ongoing training program, such as a residency. But it was very difficult to conduct the scan on continuing education because you could generally not access the content of a CE program. So you don't know what's the level of integration or what really was the quality of what was being taught about this. Also, the Joint Accreditation for Interprofessional CE includes medicine, pharmacy, and nursing, but not dentistry. So although there's a system built up for some level of IPE, dentistry has not been included in that. And of the 43 non-dental health profession associations, 42% of their websites had minimal or no oral health information on their website. Nonetheless, there are favorable changes that are occurring in education and training, such as we've noted a number of examples here, such as the nursing addition of adding the oral exam or oral assessment to the general physical exam, the nurse practitioner dentist model, the referral networks that are built within local dental practices, the National Interprofessional Initiative on Oral Health and Oral Health Nursing and Education and Practice, New England's Transforming Clinical Practice Initiative training program, notably the Smiles for Life, which has been available for over 250,000 people. And some organizations, like these mentioned here, are educating members about oral health. But it is still not a large proportion of the curriculum. So facilitators for education and training include the IPE accreditation standards that are across all professions, the oral health integration throughout the existing primary care curriculum. It's not separated into time blocks, and just sitting in a didactic lecture together does not create IPE, but that is one of the ways in which some schools are addressing hitting the mark on accreditation to say that they're taking a course together. So we need to have more focus on the clinical activities and involving students of different professions actually doing something with patients and learning from each other. We also need non-dental oral health champions and university leadership, that this is really an important thing for dental education, for oral health education. So this, in general, our conclusions are that there are few guidelines or published surveys of reported practice integrating oral health, except in the children's area. There's little peer-reviewed literature on studies of integration of oral health, and within this, most are pilot demonstrations and do not discuss effectiveness or outcomes in improving oral and general health. The professional education is developing systems to advance IPE, such as accreditation, but there's little action at the practice level. Health literacy applications are seen, and as you saw, there's a lot of examples of communication strategies that could be considered health literacy. But these are generally offered with intent by the accountable care organizations, with both normative, system, and organizational level attack at this problem, but it's more intuitive in other settings. And where we're going to really have the problem in addressing this as in a large-scale operation is to be able to work outside of managed care and ACOs, where you have the majority of dental practitioners are still in private practice. They are not in a network. They are not part of this. And so there need to be ways that we can bring those people into the network so that they are able to communicate with physicians. And this is something that has been approached by the IMB, which is a good example that you'll hear about later today. So in general, integration of oral health into primary care is still in its infancy. Thank you very much.